pathology and forensic. Develop in veins, deep veins, particularly in the legs, and break loose to the lungs. And when it does that, the deep veins of the leg, ordinarily you should not have a clot. So if you have a clot in your deep veins of the leg, it can be dislodged to the lungs. And that is what is called what? Pulmonary embolism. Pulmonary embolism. Okay? So when it affects only the deep veins alone, it is referred to as the deep veins thrombosis. And involvement of the lungs is called pulmonary thromboembolism. So we are going to be talking about venous thromboembolism. Thrombus can also be found in the arteries. It can also be found in the heart. It can be found in the lung. Okay, so we'll be talking majorly today about venous thromboembolism and pulmonary thromboembolism. So that's how like a clot looks in the middle of a deep vein. Superficial venous thrombosis is also possible, and deep venous thrombosis is more deadly than superficial. So we'll be talking majorly about deep vein thrombosis, okay? And that's the clot in the lungs. Imagine massive clots in the lung. What's the implication of that? It's going to compromise what? Oxygen supply. It will compromise oxygen supply, and the person will become hypoxemic. What's the implication of become hypoxemic? Death. So we're talking about pulmonary embolism, and that's the clots in the lung and how it looks. So by introduction, DVT, which is deep vein thrombosis, and PE are a single entity. Half of patients with DVT without clinical features of PE experience undiagnosed pulmonary embolism. Okay? So while 2/3 of patients with proven pulmonary embolism have no DVT symptoms. So it's possible to just pick PE without a DVT. DVT may be occult, and in 1/3 of cases, original site of DVT may not be found without autopsy. Okay, that is after death. It's highly prevalent. Okay, VTE is underestimated worldwide. It is estimated in the US that 1 in every 9 persons develop recognized DVT when younger than 80 years, and clinically recognized VTE accounts for 1 of every 20 deaths in those older than 50 years. 1 out of 20 deaths. That's the record from US. Autopsy studies demonstrate that approximately 80% of all cases of DVT and PE remain undiagnosed, okay, even when they are the immediate cause of death. So the diagnosis might be missed until when you do autopsy. Similarly, in Europe, 500,000 die from VTE each year, more than the combined deaths from HIV/AIDS, breast, prostate cancers, and highway accidents. You can imagine the magnitude of the problem. So if you combine mortality from HIV/AIDS, breast and prostate cancers, and highway accident, road traffic accident, is not as high as what you obtain from venous thromboembolism. In the United States, it is estimated that 100,000 to 300,000 individuals die due to venous thromboembolism each year, and venous thromboembolism is associated with more than 500,000 hospitalizations in a year. So it's a serious problem, okay, to have a clot in the deep veins of the leg. Elsewhere in the world, such as Asia and Africa, the situation is likely to be equally dire, with a lack of data masking the broad impact of thrombotic disorders. We don't have data in this part of the world. So, but if you compare what is obtainable in the West, it will not be different from what we have here. So the prevalence is highest in patients hospitalized and bedridden, okay, with serious coexisting illnesses such as cancer, stroke, and so on and so forth. However, the prevalence in ambulatory outpatient is not insignificant. It also happens in outpatient department. Okay, data was collected retrospectively from record of post-mortem reports at UCH Ibadan between 1991 and 1998 by that author, Shotunbi. Okay, of the 989 autopsy documented within the 8-year period, 29 autopsy confirmed VTE. This indicates a prevalence of 2.9. I'm sure it's much higher than what is available now. 65% of the subjects were older than 40 years, and male to female ratio was 2.62, so commoner in male in that study. Malignancy was the commonest predisposing risk factors, cancers, and that's why I said cut across all disciplines. So there is cancer associated thrombosis called CAT. So oncology is other predisposing factors include immobility for more than 4 days, neuromuscular paralysis, septicemia, multiple trauma involving the pelvis, abdomen and head, major surgery, congestive cardiac failure and obesity were all associated with VT. In Zaria, another study, 450 consecutive Nigerian patients aged 20 and above undergoing elective surgery. Incidence of post-operative DVT using clinical method was 2.2%. So it's similar to Ibadan data, which is 2.9%. Okay, of these, 333 were men and 5 had deep vein thrombosis, giving the incidence of 1.5%, while 117 were females and 5 had deep thrombosis, giving the incidence of 4.3%. So the risk of VT is increased in pregnancy, and that's why I cut across all departments because of the hypercoagulability associated with pregnancy. Okay, risk is higher in cesarean sections, C-section patients than after spontaneous SVD, spontaneous vaginal delivery. So if you go through CS, you are likely to develop a clot in your deep veins. Okay, the risk is higher postpartum than in antepartum, and the risk not associated with any trimester or pregnancy. 90% of VTE occurs in the left leg, so we will understand why it is commoner in the left leg than later during the course of this lecture. Okay, so overall mortality of untreated PE is 26%, 1/4. So you develop PE in pregnancy, 1/4 of the patients are likely to die if you develop PE in pregnancy. Women with congenital deficiencies are even more at risk, like deficiency of protein C and S, antithrombin, have a 8-fold increased risk of developing VTE. 60% of women who develop VTE in pregnancy have factor 5 leading gene mutation. Talk about that. So we're going to be talking about deep vein thrombosis. We'll be talking about the deep vein. You need to appreciate the veins, the deep veins of the leg. You know, starting from the foot to maybe inferior vena cava, and then the heart, and then the superior vena cava. So it's possible to have clots in all these veins. So 5 major veins drain the leg, 3 below the knee, and this is just a reminder of your anatomy, and 2 above the knee. Okay, the 3 below the knees are the anterior tibia vein that drains the dorsum of the foot, anterior tibia vein. Then there is the posterior tibia vein that drains the sole of the foot, and then the peroneal veins drains the lateral aspect of the foot. That is, those are the veins below the knee. So they merge to form the popliteal vein behind the knee. The popliteal vein crosses proximally behind the knee and then passes anteromedially in the distal thigh through the adductor canal to form the femoral vein. Okay, the femoral vein is the largest and the longest vein in the leg. Unite with the deep femoral vein in the proximal thigh to form common femoral vein. This proceeds to form the iliac vein at above the inguinal canal. Okay, and so if you are asked to mention the veins or the vein that is likely to be affected by a clot at the knee, what vein are you likely to talk about? Sorry, popliteal vein. Popliteal vein. What about the inguinal region? Which vein are you likely to be? Femoral, below. What above the popliteal is iliac. So these are possible CBT questions. Okay, then because you need to know this, because when you do a Doppler, are you familiar with a Doppler ultrasound? Doppler ultrasound is what is used to diagnose deep vein thrombosis. So you need to be familiar with all the names, the tibial veins, the anterior tibia, posterior tibia, peroneal, popliteal, femoral, inguinal, and okay. So this above the thigh, the iliac is a continuation of the femoral vein, passes upward behind the inguinal ligament. So above the thigh is the iliac, below the thigh is the femoral. Okay, so at the level of the sacroiliac joint, it unites with the hypogastric vein to form the common iliac veins. Okay, so the left common iliac is longer than the right common iliac. The left common iliac is longer than the right common iliac and more oblique in its course, passing behind the right common iliac artery. Are you surprised that DVT is commoner in the left leg? Based on that statement, DVT is commoner in the left leg because the left common iliac is longer than the right common iliac and is more oblique and passes behind the right common iliac artery. Okay, and that's why it's commoner to have a DVT of the left leg. The 2 common iliac veins unite at the angle to form the inferior vena cava at the level of the 5th lumbar. So there's what is called the calf pump. As you move, as you exercise, your calf, pumps, the calf muscle pump, pumps blood and pumps it upward, so and prevents any stagnation, stasis of blood. So, and that is why it is commoner with bedridden, obese patients, because there is increased stasis. Because if you are obese, you are likely to stay in a place, sedentary activity, you are not doing anything, you just sit from morning till evening. So the calf muscle pump will be inactive. Okay, so and muscle pumps of the calf and thigh provides the motive force of venous return. So if you are not moving up and down, you just stay in, so the venous return from the lower legs will be compromised. Okay, and so the most important of this is the calf muscle pump, often called peripheral heart. So we'll be talking about the etiology risk factors. There are many of them, and you would have understood one or two I've mentioned this morning. Can you mention just one? Etiology and risk. Pregnancy, cancer, sedentary activity, obesity. But we mentioned bedridden, surgery. We are stopped. Okay. Well, single most powerful risk marker for DVT is a prior history of DVT. If you have had a DVT in the past, it's the single most important risk factor. You are likely to have another one. So, but if you have a DVT and is treated and it resolves, and then you have another one, treatment is lifelong. We lost one of your lecturers 2 years ago, wife of another lecturer, to PE in CCU here, like 2 years ago or last year. So she's a consultant. She was a consultant and endocrinologist. She had PE. She was treated, had another episode of PE, and she didn't make it. So previous history of DVT and PE, and that is why treatment has to be lifelong. Once you have PE or DVT twice, it has to be lifelong, because you might not get warning when next you are going to have. So in the absence of prophylaxis, patients who have had prior recognized PE or extensive DVT will certainly develop second or recurrent VTE with surgery. Okay. Patient in leg cast, we didn't mention that. Why would that be an etiological cause? The muscle pump action is not active. Okay. Obesity, we mentioned that. Smoking, for some of you guys that are smoking wee, I know one or two people will be smoking here. Who is bold enough to identify himself or herself? Most likely to be, you don't want to mention name. Mention now. Is it Demilade? Is it general anesthesia? The patient have 500% increased risk of DVT compared with epidural anesthesia for the same surgical procedure. So, and that's why it is old-fashioned to use GA for cesarean section now in our O&G. So what they use is epidural. When I was doing house job, we were using GA. General anesthesia. What's the difference between general anesthesia and epidural?
Just looks like
from the umbilical vein down. What about the general? We use gas. You use gas to. So malignancy, we mentioned that 38% of concomitant cancer and DVT, the DVT is detected first, and then you now discover after DVT, you now say there is a cancer somewhere. DVT is common after stroke. We are not surprised because of the hemiplegia. So there will be reduced mobility. 40% of surgical patients develop DVT without. So stroke patients with single paretic leg develop DVT. You are not surprised about that. Chemotherapy will also cause DVT. Patient on chemo. The mechanism may be through endothelial damage. So, and then we are going to talk about the pathogenesis, and then so you can imagine chemo itself will cause DVT, cancer will cause DVT. So you can just, if you like, don't take chemo, you develop DVT because cancer is there. If you take chemo, you have double fold risk of DVT. Coagulopathy, deficiency of these factors, anticoagulants, will cause thrombosis, protein C deficiency, protein S deficiency, antithrombin. Hyperlipidemia, are you surprised? Why? Occlude, hypercholesterolemia can occlude the vessels and can cause stasis, cause turbulence, cause endothelial damage. So hyperlipidemia, immobility, we've mentioned that. And autopsy findings from patients dying in the hospital from any cause demonstrate P in 15% of those dying after less than 1 week in the hospital, and 80% of those who die after more prolonged periods. You can imagine if you stay longer than 1 week, 80% of causes or PE is found in those who were on admission for more than 1 week, and just 15%. So prolonged hospital admission can cause DVT. Patient in coma is high risk. Increased age is a risk factor. If you are praying to get old, you are also, whereas if you want to be old, you cannot be free of charge. The Yoruba proverb, like you can't be free of charge. You have to pay. You have to pay for the price of those of your mates that are late. How do you pay for it? Your vision may not be good, like you have to use, like me, I can't read glasses again. I can't read without glasses. Your hearing, if by the time you are getting to 80, you need to move near to say, grandma, check back. So then the osteoarthritis will set in, and then your metabolism will drop. There will be sedentary activity, there will be mobility, because ó tún wá sọ pé òun wá sílé arúgbó lọ́fẹ̀ẹ́. If you go and greet a grandma, grandma will say, okay, go and get this for me, go and get that for me, go and get this one for me, because she has been waiting for somebody to send. Okay, and that is immobility, and that's sedentary. They can, with this era of social media, those grandma be sending all the WhatsApp messages because they don't have work to do. They are at home from morning till evening, so they engage themselves, grandma and grandpa. They will be disturbing you with junks. They don't have work. Contraceptive pill, are you surprised? How? Contraceptive pill with PE and DVT. Are you surprised? You are surprised. Is the hormone estrogen, progesterone will cause what? Well, it increases. It's increases fluid, body fluid, increases body fluid, and will cause turbulence and cause stasis. Okay, and that's why it's associated with obesity. If you are taking pills, you are likely to add weight. Are you aware of that? Now that is we're going to, so pills, daily pills, polycythemia, thrombocythemia. So are you surprised? Are you surprised? Why? There is the completely packed cells, so it's going to cause stasis and then cause pregnancy and preparation. We discussed that. Antiphospholipid antibody, we discussed this last week. It ordinarily should cause bleeding because it's an antibody against phospholipid needed in coagulation cascade. So it should create deficiency of factor 8, but rather it causes thrombosis, ironically. Okay, so this old age, how we look. Everybody will look this way one day if you are old enough to get to this level. For the man and for the woman, they've been more beautiful than some of you and more handsome than some of you, maybe 40, 50 years before this picture. So pregnancy, for those that have not seen a pregnant woman before, that's how it looks. And your pill, your oral contraceptive pill,
And that's like, because I used to do more than that. Don't scatter,
so a contemporary example of thrombosis due to immobilization occurred in a young man. This was reported recently, okay, who spent 12 hours per day behind the computer screen. Eh? Immobilization in a sitting position confers a higher risk. All these yahoo boys. Eh? Long distance travel, you can see. There will be immobilization, and then the blood will not be able to flow back. So it's called e-thrombosis, electronic thrombosis, for yahoo boys. And for long distance travel, you are going to the east, you don't have money to pay for a seat, you now pay for attachment in the bus. And then you squatted for 10 hours to get to the east. You are likely to be predisposed to, or you are going abroad, you are going to New York. Because of the cost of flights, economy class syndrome is even good. You can get Lagos, New York, but because of cost, some people will go to Rwanda, go through Rwanda, 7 hours to Kigali or 8 hours, and from Kigali to New York, they will spend another 13 hours. Because it's cheaper. If you go through Rwanda here, go through Ethiopia here, go through Qatar. Qatar is also cheap. They will take you to Qatar 7 hours, and from Qatar to New York 14 hours. And then you are escorted in economy position for hours. So the teaching is that from time to time you should move out and go through the aisles, walk up and down, stand. Even if you are going to pay for Rwanda here, you are going to pay for Qatar here, you are going to the US. So the most annoying part of it is that you are going to London, which is Lagos to London is 6 hours, but you first go to Qatar, spend 7 hours to Qatar, from Qatar to Heathrow, you spend another 7 hours, making 14 hours. Then if you want the cheapest of the cheapest, your stopover time can be 16 hours. Lagos to Qatar, you now spend 16 hours in the airport. It's always cheap. Somebody just bought a ticket to UK. They're going for PLAB 2, one of your seniors, last Sukomites. So he told me, I don't have money, that he had to pay for Kenya Airways 500k, but it's 16 hours stopover. So the flight will take him to Nairobi for 6-7 hours. Now spend 16 hours at the airport before boarding to Heathrow. It's money now. If you want to get British Airways, Kenya Airways give you for 500. British Airways Lagos to Heathrow 1.8 million, 2 million, 3 million. So if you don't have money, you have to go through corner. So this is the classification. So once you are tired, just let me know. I will give up and leave. So this is the classification. You can be risk of VTE low, moderate, high, and very high. The risk is low in uncomplicated minor surgery. You want to do a biopsy, you want to do hydrography, and you are less than 40 years. I don't think anybody is older than 40 years in this class. Surgery is moderate in those with those who are 40 to 60 years old and has a major surgery. If you have major surgery in patient less than 40 years, it's also moderate. And minor surgery in patient with risk factors is also moderate. So this is the classification of the risk. So we know about Virchow triad already. We were taught in. So what is Virchow triad? That's the pathogenesis.
Stasis, hypercoagulability, and
Hyper,
coagulability,
okay,
and endothelial injury.
and stasis. So I'll just keep all the slides because that's the pathogenesis of deep vein thrombosis, the Virchow triad. So I won't waste time on that. So I'll just slip all the slides. So that we can go far. So the hypercoagulability, maybe I just mention antithrombin 3 deficiency, congenital protein C deficiency, protein S deficiency, dysfibrinogenemia, dysplasinogenemia. So what are the symptoms and signs of DVT? It's not specific. You just notice a swelling, unilateral leg swelling. Okay, you can see unilateral leg swelling, all the markers of inflammation. What are these? Eh?
Swelling,
Okay,
pain,
okay,
heat,
and edema, swelling. So that's what is usually, if you see this kind of leg, the person must go for what kind of test do we use to diagnose? Doppler, 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 Doppler ultrasound. This is another leg. You can see unilateral leg swelling is very suggestive of DVT. There can be fever, little bit fever because of the inflammation. So we'll just keep all this. So we'll talk about pulmonary embolism. Like I said, pulmonary embolism is usually secondary to DVT. The DVT may be undiagnosed and may be diagnosed. Patient is on treatment of DVT and now start complaining of chest pain. So it's not specific, then it can be no mistaken for other clinical conditions of the chest because of wheezing, cough, fever, anxiety, apprehension, tachycardia, confusion. There is dyspnea and tachypnea and pleuritic chest pain. So if you do a chest X-ray, which may not be too good, there will be cough hemoptysis in massive PE. That could be, so it may, if you see sudden breathlessness in somebody that has been bedridden, that is on cast, that is an elderly, that is a pregnant woman, that is on steroid, that is, that has cancer. So you should, that I just finished chemo, you should just start thinking about PE, okay? So it is because they usually don't have time. It doesn't give them time. Before you know it, especially if it's massive. If you just go to the ward, another ward, come back, patient is dead. Is dead if it's massive PE. So with PE, you need this. You don't use this kind of ambulance. Better ambulance is needed. This is what they use in the rural area. A cow driven ambulance. Cow or donkey donkey-driven ambulance.
Oh, it's not in Nigeria.
Well, no, it's not Nigeria, but maybe this one in the north. You needed a new Toyota Corolla. Also something better than this. Toyota Corolla.
It's like, I don't even know what it is.
This Toyota Corolla, cow.
The patient would have died.
The patient would have died. Eh? The patient would have died. Eh? Before you get there. So you need what you need is Tobi Amusan type of race. You need Tobi Amusan. If you are dealing with PE, you don't have luxury of time to be, even if the patient does not have PE, just start anticoagulant, start heparin immediately. Then you now discover that the patient does not, it's okay, you won't be reprimanded for that. But if you miss PE and say, let me go and do CTPA, let me go, and before you come back, patient is dead. So what's the importance of your investigation? So that's why I'm talking about advocating you to use this style. Tobi Amusan.
Emergency doctor.
So these are the differentials of the DVT. Muscle strain, lymphangitis, lymphedema that can mimic that unilateral leg swelling, okay? Venous reflux, Baker cyst, which is a pressure diverticulum of synovial membrane of the knee. So cellulitis can also mimic it. Bone or soft tissue neoplasia, superficial thrombophlebitis, tendinitis. In pregnancy, physiologic leg swelling during pregnancy. But for PE, pneumonia can mimic PE, pleuritis, atelectasis, all this can mimic PE. Pneumothorax and tension pneumothorax, so can also mimic. So you need to act fast for PE, like I've said. So there is a clinical at the bedside. I don't know whether you've heard about well score before. You've heard about well score? Yes, no. Okay, so this is what you use. This is what you use if you are not sure whether the patient has DVT or not. So you call the patient on this. So previous history of cancer is 1, paralysis or paresis or recent plaster immobilization 1. So DVT is likely if the score is 2 or more. DVT is likely. So if DVT is likely, before you even start any investigation, start treatment. That's the importance of well score. Before you start any, okay, we want to order for Doppler, we want to order for CT, we want to start heparin before. So that's the importance of the two level. So this is for PE. If you are suspecting a patient has PE, this is the score for PE. But PE is likely if the point is 4 and above. So you need to know this. Clinical signs and symptoms of DVT is there. That's 3 already. That's unilateral leg swelling is 3. Okay. And in any other one that will make 1, like hemoptysis 1. So that's 4 already. Start PE treatment. Okay, that's the importance of well score. Okay. If the patient history and symptoms and physical examinations suggest a venous DVT, so you have to do this following test. Like I've said, Doppler ultrasound is the commonest that can make the diagnosis. Doppler ultrasound is the commonest that can make the diagnosis. But there are other tests, contrast venography, MRI of the leg, CT or CAT scan of the leg, and so on. Impedance plethysmography measures blood flow in the limb. But we don't do this all. Okay, so you can also do a D-dimer test that is higher than, if it's higher than 500 nanogram per mil, it's very suggestive. For PE, then you do SpO2, and then you can do ABG, arterial blood gases. And then you can do, what is the commonest test? Imaging test for P. P for P. CTPA, CT pulmonary angiogram is what you do for P. Is the commonest test that you can use to make a diagnosis of PE. CT pulmonary angiogram, which is called CTPA. And for DVT is Doppler. Okay. So once you make then for hypercoagulability, you have to do all this screening, whether they are, whether they are deficient. So, but you can also, there are some indications for VTE prophylaxis, because some of these medications you have prophylactic doses and then therapeutic doses. So you don't want to wait until patients develop DVT, particularly if you are suspecting the patient is at risk of developing as etiological factors that will cause DVT. So you don't want to wait. You can give prophylactically. Cancer patients that is going for chemotherapy and has failed well score. So you can then, but for total hip replacement, it's permissible to give prophylactic anticoagulant, hip fracture surgery, total knee replacement, lower leg fractures and injuries with immobilization, general surgery, major abdominal surgery, minor gynecological surgery. For sickle cell patients, pregnant sickle cell patients, they are routinely placed on anticoagulant. But by the time they are getting to delivery time, your anticoagulant can tip them into bleeding. So you have to stop. But if you don't, so I just saw a patient 2 days ago, sickle cell at CCU. So sickle cell patient, bilateral leg DVT, during pregnancy, bilateral leg, and then had PE during pregnancy, but survived and had CS for a twin pregnancy. No, her name is Oriyomi. But found herself on admission because of, she has escaped the postpartum period and they've now recommenced treatment for the DVT because DVT is still there. And then she started pouring per vagina. Pouring blood. Is it water? Is it water she will pour per vagina? Pouring blood. So I was contacted. So they commenced on apixaban. We'll talk about it, which is antifactor 10 drug, 10 milligram BD. So when I saw, and I just told them to, despite the DVT, despite the bilateral DVT, to withhold anticoagulant. Because if she bleeds to death, what are you going to be treating? So we now gave, what should I have requested for, from your knowledge of hematologists, to stop the bleeding? And I requested for it. And the bleeding subsided because I called yesterday. No longer bleeding. No longer bleeding. FFP. Yeah. Why? Why are you surprised? Why? All the factors are there. All the factors are there. They just gave her 2 pints of FFP yesterday. No more bleeding per vagina. So she's still stable. No.
She was on anticoagulant before now.
She was on anticoagulant, which are anti-factors. They are inhibiting the factors. So if you are replacing the factors, then
Sir, how long will it be before you play that treat that start treat that again?
No, once she's stable, no more bleeding. We are sure there is no more bleeding. So we will recommence at a lower dose of the anticoagulants.
Tomorrow, next week.
We are still watching because we don't want to trigger once we discharge. But the challenge that if you don't treat the DVT, the clot can be dislodged. Again, go to the lungs. No, okay, we'll talk about that. We'll talk about that before the end of the lecture. We'll talk about it. So you can see, so but you should also not have, you should avoid anticoagulants in some clinical conditions. Knee arthroscopy. Why will you want to avoid it? If you bleed to the joint and you are doing arthroscopy, then the patient will bleed to the joint. Head and neck surgery to cancer surgery, you have to avoid anticoagulants. Use with extreme caution in neurosurgery because once they bleed, wow, then you now be looking for how to remove the blood clots. Urological surgery too, it can be very bloody, so you have to be careful. Prostatectomy is the doctor just died like 2-3 weeks ago here in the CCU from prostatectomy associated bleeding. Was bleeding, had 17 units of platelet concentrate, 40 units of FFP before we were invited. And then no FFP, not O blood, but there is a coagulation derangement from prostatectomy. So they were trying to stop that. So it is possible. Doctor still died anyway. So bleeding, the doctor bled to death. No, bled to death. So one has to be careful with ischemic stroke, general medicine, so indication for anticoagulant in pregnancy is also there. The patient that is pregnant and has proven deficiency of some protein C and protein thrombophilia. Then somebody that has mitral valve disease, atrial fibrillation and pregnant. So myocardial infarction, severe left heart failure must be placed on anticoagulant, okay? Pregnancy complications can also, so as you are trying to manage bleeding, you are also trying to manage clots. Because if you have DVT, if you don't treat, it can be dislodged and then cause embolism, thromboembolism, and then pulmonary embolism. But if you treat, you can also tip the patient to bleeding, like that sickle cell patient I talk about. So the mainstay of treatment is anticoagulant. You ask that question. The mainstay of treatment is anticoagulant. Antithrombotic, which are anticoagulant, prevents formation of further clots, but it will not break down the already because of bleeding. They can tip them into bleeding. That's the challenge. If you give, if you gradually, so it will going to dissolve gradually. So it takes 6 months minimum to treat. But if you have an emergency massive PE, you must give thrombolytic. But because you can still live with DVT, thin out the blood with your anticoagulant, then gradually it's going to the clot will resolve and then become thinned out itself. So the difference between antithrombotic or anticoagulant and thrombolytic agents is that thrombolytic agents break down already formed clots, unlike the antithrombotic that will prevent formation of further clots. So these are the examples of thrombolytic, or also known as fibrinolytic agent, TPA, streptokinase, and so on and so forth. So with time.
It eventually causes embolism. You can't see the smaller parts now will swell
and get dislodged. If the patient is adequately anticoagulated, it is very, very unlikely. And I've told you because of risk of bleeding. Bleeding is more dangerous, so, and it's an emergency situation. Except you are also dealing with emergency situation like in PE, massive PE. You are dealing with emergency situation. You have to use thrombolytic agents and not anticoagulants. But if the patient can live with it for months, why do you want to create unnecessary panic for the patient? And based on clinical experience, most people with DVT and anticoagulant, they do well after 6 months on treatment, 7 months on treatment. Okay. Which other doctor? She died. You said what? No, she had a repeat P. Before she was consulting at Air Force Medical Center. So it happened there. Before she brought her, it was BID, second P. So there was no time to run around. That's why I mentioned those. I showed you that ambulances because of my experience. So you could have arterial, venous, or cardiac thrombosis. Okay. So these are the various anticoagulants and their dosages. Okay. I'm not sure you are aware of rivaroxaban. It's not clear. That's Xarelto. Okay, we have two major types of. I hope you are all listening. Okay. We have the warfarin, which is the old reliable anticoagulant of warfarin, and you have direct, and it's not specific. I hope you are aware. It's what are the clotting factors that are picked by inhibited by warfarin. Clotting factors that are inhibited by warfarin. Vitamin K dependent. So we have newer agents now that are specific for just, you don't need to pick 4 clotting factors to inactivate. Just pick one and that's all. It's okay. Do you understand the logic?
Yes, sir.
So they have factor specific inhibitor, only one factor. They are called direct oral anticoagulant, or called DOAC, direct oral anticoagulant. You didn't do that in pharmacology. Okay, so the direct oral anticoagulant, we can just pick factor 10 and that's all. It's okay. You don't need to bother about factor 2, factor 7, factor 9 again. Once if you have hemophilia, it's just one factor that is deficient. The patient is bleeding. Factor, if it's hemophilia A, is factor 8. So why do you want to inhibit factor 2, factor 7, factor 9, factor 10 when you can just inhibit just factor 10 and then the patient is good to go? So you have factor 10 inhibitors. One of them is rivaroxaban. Rivaroxaban is oral. You have factor 9, just factor 9, dabigatran is one of them, and their trade name is Xarelto, Pradaxa. There's apixaban, which is also factor 10 inhibitor. The sickle cell patient was placed on apixaban, 10 milligram BD. And then you have warfarin, the popular warfarin, and then you aspirin for those with arterial thrombosis. If you have arterial thrombosis, you can combine anticoagulant with antiplatelet, and that's the dosage. Enoxaparin is the low molecular weight heparin can be in two forms, can be high molecular weight and low molecular weight. The low molecular weight of heparin is enoxaparin and is also popularly known as clexane. Popularly known as clexane. So it's usually given subcute. It's given subcute. So, and it's usually 1 milligram per kilo twice daily or 1.5 milligram per day. It is not captured in that slide. 1.5 milligram per day or 1 milligram per kilo. The high molecular weight heparin is usually given intravenous and not intramuscular. Why don't you want to give heparin intramuscularly? Hematoma is the reason. Patient can bleed into the muscle. You don't give intramuscular because of hematoma into the muscle. It's only intravenous. Subcute is preferred for low molecular weight. You give subcute. And the other rivaroxaban is oral, which is antifactor 10. The antifactor 9 is oral. Apixaban, which is antifactor 10, is oral. And that's the dose. Okay?
Which one is the high molecular weight?
Heparin. Unfractionated. Unfractionated heparin is high molecular weight. Then when it's fractionated, it's low molecular weight. Enoxaparin, yeah. So this is just to remind you of how you've seen this before. Okay. Okay, so this is how they work. The heparin will combine with antithrombin to inhibit all the clotting factors. Which are the clotting factors inhibited by heparin? Those are the clotting factors. 12, 11, 9, 10, and 2. So those are the clotting factors. And look at warfarin too. Those are the clotting. Okay, there are other anticoagulants with fondaparinus, which is anti-factor 10 too. You can see fondaparinus, and then you can see the low molecular weight heparin. And you can see dabigatran, which is Pradaxa, which is anti-factor 9. Antithrombin, sorry, antithrombin. Dabigatran is anti-factor 2, not factor 9. Dabigatran is antithrombin. And so these are the mechanism of action of all the, like I said, instead of inhibiting those heparin, warfarin will pick 4 or 5 clotting factors, inhibit them. The direct oral anticoagulant will pick just one. Okay? And this is another mechanism of action of heparin and other antibiotics. So there's what is called direct thrombin inhibitors. They just pick on factor 2 and then inactivate them. And there are some of them, lepurudin, agotraban, and bilivarudin. So these are the direct thrombin inhibitors that we just. So this is the dose for the unfractionated. The challenge with the low molecular weight heparin is it is not suitable in those with CKD, renal impairment. So low molecular weight heparin should not be used. So use unfractionated heparin. Okay, unfractionated heparin, and that's the dose 75 to 100 units. It comes in units per kilo intravenous bolus over 10 minutes, and that's the maintenance dose and monitoring of heparin. Okay, this is another table showing you have to monitor APTT. APTT because if you are giving heparin, you are not sure whether the patient is adequately anticoagulated or not. Your APTT must be monitored, and it has to be at least 1 to 1.5 over the control, over the control, to be sure that, because if you are over anticoagulating, then you are tilting the patient to bleeding. You do APTT and it's like 5, you must immediately stop. So that's the importance of monitoring with when you are using. So that's the, the comparison between unfractionated heparin, which is high molecular weight heparin, and low molecular weight heparin, the dosages, and you can see you need to dose adjust if the creatinine clearance is high for low molecular weight heparin, but it's safe with unfractionated heparin. Okay, then I must also mention that warfarin is not safe in pregnancy. If you have DVT at 3 months of pregnancy, you have to be on subcute clexane till you deliver. Yeah, that is enoxaparin, low molecular weight. And for an ampoule of clexane, which is the enoxaparin, low molecular weight, is like 10K, 10,000. So that means 10,000 till you deliver from the 3rd month of pregnancy every day. Yes, that's what some people face. That's what they face. If you have DVT, maybe at 3rd month of pregnancy, warfarin is not safe, and all the DOAC are not safe. They've not been tested to be safe. They've not been tested to be safe in pregnancy. So you need to use. If you don't use it, you know the implication. If you don't use it, you know the implication. If you have DVT, like that sickle cell alone is enough to cause DVT. Carrying twin pregnancy is another wahala. Then pregnancy itself is another wahala. So you now have bilateral DVT. Wahala. So if you cannot use warfarin because of teratogenic effects on the baby. Warfarin can cause teratogenic effects. So unless the person is on admission from the 3rd month to the 9th month, they will be giving the person high molecular weight or unfractionated heparin, and that's another expenses. So it's better you buy your 10,000 naira drug every day till you deliver. I said every day, otherwise the cloth will get dislodged though. Yeah, that's death now. That's why anybody, like I mentioned one of my lecture, anybody that carries pregnancy to term, even if you are fighting with the person, just congratulate the person because of all this risk associated with pregnancy. So this is the dosage for high molecular weight heparin. So because it has to be given intravenous in that dose or subcute in that dose. But if there is an antidote if patient is over anticoagulated called protamine sulfate, and that's the antidote for high molecular weight heparin. So this is one of the side effects of warfarin. Like I said, it's not safe in pregnancy. That's skin necrosis. So intravenous high molecular weight heparin has been replaced by subcutaneous low molecular weight heparin like enoxaparin. And the reason is subcutaneous, you don't need to monitor clexane. You don't need to monitor APTT. It is safe. Unlike if you are using high molecular weight heparin, you must monitor use, because if you don't monitor use, you can tilt the patient to bleeding. Okay, so that's the advantage, is that fewer bleeding complications. I'm talking about the low molecular weight heparin, and that's the enoxaparin. Much easier dosing, and then better therapeutic window. No need to monitor treatment. There is no need to monitor treatment with low molecular weight heparin, and faster and more reliable results. You just pick on either factor 10 or factor 2. Okay, if you are using rivaroxaban, it's just factor 10, it's going to inhibit. If you are using dabigatran, it's just factor 2. Okay, and you don't need to do any test. So similarly, if you are using DOAC, you don't need to monitor. But if you are using warfarin, how do we monitor warfarin use? What test do we do to monitor warfarin use? What test do we do to monitor warfarin use? No, no. We use INR. We've said this over and over again. INR is used to monitor warfarin use. So what's the formula for INR? We mentioned this at the last time. Formula for INR: PT test over PT control raised to power ISI. What is ISI? So how do you get your ISI? No, that's the control. That's the control. You know, I said, so how do you, I didn't mention how to get the ISI. Okay? Or did I mention it? ISI, International Sensitivity Index, comes in the leaflet of the warfarin bottle that you bought for the test. So if you check the leaflet, ISI will be there. Okay? So if you do the PT of the test, how do you do PT of control? You pull 20 samples together, or in using what kind of bottle? Somebody is saying EDT again. Citrates. In what ratio? You ask me. In ratio 1:9. And then you get how many mils of blood? 4.5 mils. I mentioned that. So, and you do that for 20 different people. Why do you need to do for 20 different people? Little, so that it will balance up. That's why it's called control. So if you do the PT, so how do you do prothrombin time? How do you do prothrombin time? Get a water bath. Prepare your sample. How do we prepare the sample? Make it PPP. You get a PPP. I mentioned it last time. What is PPP? We make a. Also, how do we make a platelet poor plasma? You centrifuge first time, decant the supernatant. Centrifuge second time, decant the supernatant. That's a PPP. The first supernatant is PRP, platelet rich plasma. So you get a PPP of your patient, and then get PPP for each person you are going to use as control, and then you mix everything together, and then aliquoting. I mentioned aliquot. What is aliquoting? I mentioned it last time. What's aliquoting? Getting small sample each and then freezing it so that you don't have to store all your control sample. You know, dispense it in little bottles called cryovials, okay? And then you freeze. So each time you want to do a test, you pick one cryovial. I'm sure I'm going to repeat myself again, but you will not have opportunity again because this is my last lecture with you until the next block, which is oncology, hemato-oncology. And that's why I'm repeating this coagulation for you to understand. Okay? So you make PPP, okay, of the patient, make PPP of the control, and then mix all the control together. Mix Demilade with what's your name? Precious. Mix with yours, mix with us, mix everybody together, and then dispense in little quantity. Okay, and then you freeze. Okay, so each time you want to do a prothrombin test, you pick one thaw, because if you are thawing, you are freezing. If you don't dispense it, and that's what is called aliquoting. Okay, if you are thawing, you are freezing. Each time you want to do test, you do one prothrombin time test today, you are not doing another one until 4-5 days. You will be losing the clotting factors gradually. Okay, So that's why you don't want to freeze. So if you do a PT of control and then you are getting normal value, what's the normal value for a prothrombin test? Normal value 10 to 13, 10 to 14. So if you do that, you can confidently say that your reagent and your kits are okay. Okay, so you now do that of patient on warfarin. Are you expecting to get normal value? uh, why? Anticoagulant effect. It would have inhibited clotting factor 2, 7, 9 and 10. So the bleeding time will be increased. So you are going to get, for example, somebody on warfarin, you are going to get a prothrombin time of 40 seconds. So but for your control, you got 10 seconds. So what's the PTR? I want to bring another dimension. CR. PTR is prothrombin time ratio, excluding the ISI. Okay, what's the PTR of that patient? 40 divided by 10, because the prothrombin time of the patient over prothrombin time of control. So what is the PTR? 4. Okay, the PTR is 4. Okay, so why ISI? That's the next question. If you are using warfarin for somebody that must be adequately anticoagulated, the INR must be between, if you are treating DVT, between 2 to 3. MCQ question. I'm repeating myself. For mechanical heart valve, what the INR? 2.5 to 3.5. Okay, why ISI? Why not limit it to PTR? ISI, International Sensitivity Index. Okay, you know why it is important to include the ISI? Because various manufacturers are producing thromboplastin. Okay, various manufacturers, we are producing thromboplastin in UK, in US, in Germany, not in Nigeria anyway, and so many others. So in order to have a standardized result, because you cannot vouch for the concentration of, so if you are a producer of thromboplastin, which is the reagent used for prothrombin time, you must standardize your reagent with the WHO produced thromboplastin, so that everybody will standardize their reagents produced with the WHO, and whatever you have obtained should not be too far away. If the WHO thromboplastin is 1, if I produce a thromboplastin in UK and the thromboplastin is good, it should be 1.1, maximum 1.2. Okay, so and that is my ISI that I must include. I hope you have understood. You want to come again? Come again. Okay, come again. You come again.
Why is it important for them to have the ISR?
Speak up.
Why is it important for the ISR to be on the offering bottle? It's because of, we cannot vouch for the thromboplastin reagents used when producing the ISR.
Why producing the thromboplastin?
Why producing the thromboplastin?
Okay.
So they have to be like,
standardized. Standardized. That is the right word.
They have to be standardized
Against.
WHO thromboplastin.
Okay, so that's why whatever you have obtained, when you come to hematology residency, how standardization of thromboplastin is done is a practical for the exam. So we'll give you thromboplastin and ask you to standardize against another thromboplastin. So you then now get your ISI. Do we know how to get your ISI? So what the PTR is for, don't forget. So 4 raised to power if the ISR is 1.2, that would be 4 raised to power 1.2. Does that make sense? That's the INR. Oh, yeah, do the calculation. 4 raised to power 1.2. And whatever you get is your INR. Okay, international normalized ratio. 4 raised to power 1.2 is what? If you know how to use the calculator well. 5.27. So if you have an INR of 5.27, the patient will bleed to death. If you don't stop on time, you must stop that warfarin on time. So that's the importance of the INR. Is it difficult? Because this one, you come across it in practical, you come across it in essay, you come across this, what I've just described this morning, you come across it in your CBT. So you better understand it well. I hope that is clear. I won't go over it again. So it's the same thing, anticoagulant in pregnancy, we've discussed it. And then this is what you do during delivery. Because if a patient has DVT, third month of pregnancy, patient is on warfarin, patient is going for CS after 9 months. On heparin, sorry. Yeah, you got it. You are following the class. Not warfarin is contraindicated in pregnancy. You can't use warfarin. So patient is going for CS. So you are faced with the risk of bleeding if you don't stop the heparin before the surgery. You are faced with the risk of thrombosis if you stop it too early. So you must balance the two. So there's what is called bridging anticoagulation. This is not for your class. So how do you bridge? I've deleted those slides. You bridge so that you don't tilt the pregnant woman into bleeding, and you also avoid thromboembolism. So these are complications. So these are the complications of warfarin in pregnancy. It is teratogenic. Warfarin embryopathy is called. Nasal hypoplasia, stippled epiphysis, and so on and so forth. Warfarin is teratogenic. It is no in pregnancy. Don't go there. Okay, so there's what is also called heparin-induced. That's the side effect of unfractionated heparin. Heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. But ironically again, thrombocytopenia is expected to be associated with bleeding, but heat, which is known as heparin-induced thrombocytopenia, is associated with clotting. So that's the side effect of. It's cheap. It's cheaper than your Clexane of 10,000 per day. Unfractionated heparin for those 1,000 naira. 1,000 naira. Narrow therapeutic window, risk of heat, heparin-induced thrombocytopenia. Then you have to monitor. No, CKD is for low molecular weight. You can't use CKD. You can't use low molecular weight in CKD, but you can use high molecular weight in CKD. So if you are talking about the disadvantage of high molecular weight heparin is heat, heparin-induced thrombocytopenia. Then you have to monitor to do APTT. Although it's cheap, 1,000 per day, you have to do APTT, which is like 7K for each test. It's 7K because if you don't do APTT, what is the expected range if a patient is adequately anticoagulated? I mentioned it. It should be like 1 to 1.5 of control. Okay, over the control, at least 1 or 1.5, not more than 1.5. Okay, so it's like what you are losing, what you are gaining from not buying low molecular weight that you don't need to monitor You don't need to monitor low molecular weight. It's expensive, but if you are using cheap or cheaper alternative, you must monitor with APTT. Okay, so that's about heat. Heat, you can read about it. Heat is, no, not every day, maybe every three days. Pay 7,000 for it. Otherwise, you don't know whether you are doing well, patient is doing well or is not doing well, or you want to wait until the patient bleeds into the brain. No, you don't want to wait. So you need to monitor it. So these are drugs that can interact with warfarin. Warfarin is not, apart from the fact that you have to monitor INR, patient is on warfarin, you need to monitor INR. There are also drug interactions with warfarin. There are some drugs that will increase INR if patient is on it, especially those with comorbidities. Okay, I have the list here, can be part of your CBT. Let me show you the list so that you can concentrate on it. Drugs that can interfere with INR. No, if patient is on these drugs, antibiotics, and the patient is on warfarin, it will increase the INR. Drugs that can reduce INR. These are also common plausible questions for those preparing to travel. So you have to memorize all these antibiotics and how they affect the INR. Okay, so this is the dosage formula for warfarin, and then so this is the bridging I was telling about, but you can just, okay. So again, you have to balance. There is what is called Shadva score. Did you do that in medicine? And Asbled score. You are going to do that in maybe intermediate cardiology posting. Shadva score. You score the patient and assess the risk of thromboembolism. You use those Shadva score to score them. Then Asbled score. You score the patient. Now if the patient on warfarin, I hope this patient will not bleed. Risk of bleeding. So you have to strike the balance between, for example, if the patient has congenital heart failure, that's one for Shadva score. If patient has hypertension, is one. So all this, the patient, the C is congenital heart failure, the H is hypertension, the A2 congestive heart failure. So the first A, you can see A2. The first A is age between 65 to 74 years. And the second A, in A, is A superscript 2. The second A is greater than 75 years. So if the patient is greater than 75 years, you score 2. If the patient is between 65 to 74, you score 1. So you now calculate at the end of whatever you have obtained, and then determine the risk of stroke, or that's thromboembolic stroke, thromboembolic stroke. And then you also compare, you strike a balance with the Asbled. So I think, okay, how do you, if patient is, so this is the reverser of anticoagulation. It's called HT. H is hold further doses of anticoagulant. If you want to reverse anticoagulation, A is consider antidote and supportive treatment. So this is the HT. Okay, so reversal of warfarin, this is how you reverse if there is overcoagulation. If you overcoagulate with warfarin, this is what you do to reverse it. You can find time to read it. I think this is the rivaroxaban I mentioned. This is factor 10 inhibitor, which is Xarelto is the trade name, and this is how it is used. Dabigatran is antithrombin. So this is the dose. So I think I've given you enough for today. So good afternoon. Well done. Demilade.